I don't share much about PeopleRain with our community, but I'm going to break protocol. PeopleRain is the product version of the ethos behind this great Team Human community. Our team is passionate about giving the next billion employees back 4 to 6 hours of productive time per week. Hundreds of organizations around the world trust PeopleRain to automate work because it's the safest, most trustworthy, and smartest way to automatically execute thousands of common IT and HR tasks. Consider it the antidote to AI that's either creepy or that poses a threat to human jobs. I'm hosting a live webcast where I will show a demo of agentic AI in action. Register for the webcast at peoplerain.io. That's people, reign like the reign of a queen or king.io. Now back to this week's amazing episode.
And to your point, it's not hard to imagine that there is some future state where you are getting all of the care from an AI, even if it requires in-person vaccines or lab tests or procedures, that can be done with a robotics effector arm. And hard to opine on how far away that may be, but at least the software component of that, the fully autonomous cognitive piece, feels like we're not too far away, a matter of years, not decades.
Yo, it's the future, don't hit the snooze. AI is here giving humans the boost. Team Humans rolling, brains in the game with Dan Turchin. Y'all remember the name. PeopleRain in the mix, no stopping the flow. Better work, better life, yeah, we're ready to go. Robots and humans, a collab, you know. Okay, let's start the show.
Good morning, good afternoon, or good evening, depending on where you're listening. Welcome back to AI and the Future of Work, episode 394. I'm your host, Dan Turchin, CEO of PeopleRain, the AI platform for IT and HR employee service. If you're not yet, go ahead and subscribe to a weekly newsletter. We will share a link in the show notes. And of course, if you like what we do, forward a link to this episode to just one friend. That's all we ask. They'll know that you care about making humans better with technology. If you leave a comment, I may share it in an upcoming episode, like this one from Damien in Buenos Aires, who's a fintech entrepreneur. Damien's favorite episode is number 203 with Dave Kellogg, SaaS Whisper and EIR at Balderton Capital about the future of AI, Silicon Valley and venture capital. I should note Dave's also, I think, the first four-time guest on the podcast. We do that episode annually. It's always a great one. We learn from AI thought leaders weekly, and of course, the added bonus, you get one AI fun fact. Here it is for today. Jim Gallagher writes in Commencement about proceedings from the most recent Association of Molecular Pathology annual meeting about the limitations of big data and probabilistic reasoning to maximize AI's benefits for clinical outcomes. In it, he shares a summary of comments from Dr. Tukunda Matos, who challenged the widespread assumption that adding more genomic, imaging, and clinical data automatically produces better AI models. He shared estimates showing that healthcare now generates between 14% and 30% of all global data, yet only a small fraction is analyzed or used meaningfully. Bias is inescapable when it comes to AI systems because it's built into the parameters of operation. All the decisions made when designing the systems, which data sets we choose to select, what our training sets are going to be, what our validation sets are, the way we're annotating the data, all introduce limitations in terms of the kinds of outputs that we're going to get. And even if a system could be designed with no bias, there's still a possibility of introducing biases when it's used. It's an interesting article. Of course, I'll share a link to the full version in the show notes. My commentary on this one. This level of discussion about AI as a probabilistic technique that applies Bayesian inference at scale is an important way to ground all AI ethics discussions in data, human decision-making, and human bias. Personifying AI, specifically anthropomorphizing it as teammates that interact with human colleagues, is dangerous and it's irresponsible. The goal should never be to replace humans, even though AI models trained on natural language can appear to be intelligent. Let's all take a lesson from the best physicians and practitioners in every field who know when and how to use AI to make better decisions without abdicating responsibility for outcomes that impact other humans. That's a topic we discuss a lot on this show, and we'll continue to do so. In today's conversation, for example, Dr. Muthu Alagappan is the founder and CEO of Counsel Health. the company that's automating access to high-quality, personalized medical advice from doctors. Counsel recently closed its $25 million Series A, led by Andreessen Horowitz and GV, Google Ventures. The company previously raised an $11 million seed round that included A16Z, plus Asymmetric Capital Partners, Floodgate Fund, and Pear VC. Great list of investors there. Before founding Counsel, Muthu was the CMO of Notable Health for 4 years and was an attending physician at Beth Israel Deaconess Medical Center and UCSF Medical Center. He graduated with his MD from Stanford. He also holds a BS in Biomechanical Engineering from Stanford. Go Cardinal. And without further ado, Muthu, it's my pleasure to welcome you to AI in the Future of Work. Let's get started by having you share a bit more about that background and how you came to found Counsel.
Well, first of all, thank you, Dan, for having me. Very excited to be here, and thank you for the generous introduction. So my background is a bit multifaceted. So I actually started my career as an AI researcher at Stanford. I grew up just really interested in data science and the applications of technology in medicine, and so spent a lot of my time, both as an undergrad and soon after, looking at how to apply AI in clinical domains. Now, this was over 15 years ago, and at the time, there was a very small but dedicated community of researchers who cared about this intersection. But I don't think any of us could have predicted the level to which these two domains of clinical medicine and AI would one day intersect. But at the time, there was this community, and I found it fascinating. So we published some of the first papers on using AI computer vision to detect polyps during a colonoscopy more accurately than a human endoscopist. We published papers looking at whether AI could predict your end-of-life preferences more accurately than your family members could on your behalf. And so had always just been really fascinated by the power of machine intelligence. I then went on to become a doctor myself, as you mentioned, trained in Boston. I'm an internist by training and spent time as both a PCP and a hospitalist. After that, came into startups and operating roles as a way to scale my impact, going beyond just maybe one patient and one visit at a time to building systems and technology that could help populations. And I did that at Notable Health for 4 years before leaving to start Counsel. And in some ways, I say I'm an AI researcher and PCP who's building AI for primary care. And so it's been really nice to see those worlds collide.
I've heard you talk about having lived the problem as a primary care physician. Maybe describe the role that AI can play to deliver better patient outcomes. And I know it's a big part of the founding vision for Counsel.
Sure. So, as a PCP, even at some of the, what are considered the best medical centers, I still saw how much of getting it right depended on people being their best and doing their best every moment of the day. It felt like we were putting a lot of responsibility on people and their biases, their intelligence to sort of serve patients as well as possible. A lot of emphasis on their principles, on their memory. And even at the best medical centers, we saw many instances where that fell short. I remember being a PCP and having a medical assistant hand me a Post-it note before every visit with the list of care gaps that patient needed to close. I remember, scrolling feverishly before primary care visits to get caught up on the patient's medical history as you're running back to back between visits. Or even being asked questions by patients that, despite my best knowledge, I may not know the answer to or be familiar with. Questions about supplements, about lab tests that are not commonly interpreted. And what I think AI has sort of led us to believe, and sort of the promise behind it, is that we can augment human intelligence with machine intelligence in a way that covers a lot of knowledge gaps and allows patients to experience something that feels closer to perfect. And when we say this sort of pursuit of perfection in medicine, we're referring to a care experience that is extremely personalized, always available, and infinitely knowledgeable. So a system that knows you better than you know yourself, a system that's available to you at all times, not only when the doctor happens to be available, and a system that's knowledgeable enough to retain within itself kind of the entire landscape of medical knowledge, of information, of guidelines, much more than any one human could do.
One of the things that stood out from a recent interview that I listened to with you was the humanness of the doctor side of the doctor-patient interaction. And as a patient, you kind of expect that doctor shows up, you get whatever you get, your 15 minutes or whatever, and they're an expert. They're at the top of their game. They have perfect recall. Because for you, that's the only visit you have that day as a patient. But for the doctor, you're distracted, you're grumpy, you're hungry, you're human. And to be able to augment, your the limited scope that you have going into that conversation with machine intelligence just seems obvious when you hear you describe it. But how do you respond to patients who say it's creepy or it's dehumanizing the experience, which obviously I'm sure comes up a lot in your conversations?
Yeah, it does come up. And, interestingly, I think we're seeing a phenomenon where in certain demographics and even parts of the country, patients may be actually more accepting of the use of AI in medicine than even doctors are. And sort of some of the data behind that is just the number of patients that turn to platforms like Claude and ChatGPT for medical advice. And so it seems like there's actually increasingly acceptance that speaking to an AI for medical information is actually a very reasonable thing to do. And we may actually see patients leapfrogging clinicians in their willingness to adopt AI in this sort of sacred domain. We may actually find, when all is said and done, that it's physicians who drag their feet the most on this technology really becoming mainstream as it starts to eat away at sort of, as a physician, your own sense of self-worth and importance and meaning within this profession. Humans cared for each other for the last 25,000 years of human civilization. And so the idea that we could be living through in the next 2 to 3 years a transition in that is like, from an existential perspective, is very threatening. And so, again, patients could adopt this sooner. Now, we do hear concerns about, is this, what about my data? Is this, what if it steers me in the wrong way? Is this creepy? But I think a couple of things. One, some of those concerns are even more amplified when it's a human. A lot of people actually feel more safe and more private sharing with an AI than they do sharing their alcohol use and their substance use and their family history with another person who you may run into at the airport or the grocery store later that day. And so there is an element of that where the AI actually may be a bit more accepting of those vulnerabilities of who we are. And then the other thing is, at Counsel, we often talk about something called semi-autonomous care, which is it's actually possible to retain the best of both worlds. You can have a human in the loop so that you have that feeling of reassurance, the human compassion, the human touch, but still augment with machine intelligence. And so semi-autonomous care becomes like a nice way to sort of get the best of both worlds to enjoy the benefits of humanness as well as machine intelligence.
Seems to me like in this domain, it's kind of a commons problem in that the patients want their care to benefit from the doctor having access to everyone else's information, but they don't necessarily want their information to be shared with other patients. And I know that's oversimplifying it, but maybe talk about the data strategy, what's stored, how it's shared, how it's used from the perspective of Counsel.
Yeah. So even on that point, it's a really good one. And there is a way to do both because we can anonymize, scramble, de-identify the data such that we can learn across populations without exposing or sharing any one person's specific data. So the way, to do that is, you can, of course, anonymize and de-identify, and then you can effectively scramble the text of the conversation. So it's not their words. It may not even be their diagnoses. We've just sort of swapped everything in a way that's sort of one for one, but totally not recognizable, but still then elicit population level patterns. Like we have a sense of whether there's a rise in an environmental phenomenon in a particular zip code, or if there's a spike in an infectious disease somewhere else. Now at Counsel, we don't train our models or improve our models based on any patient data. So that has been totally sort of off limits. However, we do things like we'll take anonymized versions of patient conversations and we'll use it to see if an AI did its job. So more of a grading than it is a training. And so we can look back retrospectively at 10,000 anonymized conversations and say, how often did an AI counsel the patient on potential side effects of this antibiotic. And our benchmark is that it should do it in 98% of circumstances. And did it meet that goal or not? And so we're not training the model, we're not improving the model, but we are getting real world evidence on, is the model performing effectively?
Is there also a component of counsel whereby the doctors can interact with notes or with transcripts from conversations they've had with that patient in the past, just on a one-to-one basis?
There is. And so the way counsel works is you come to us with medical concerns the way you would come to any doctor. You begin by talking to your medical AI, which is an AI system that has been trained in clinical skills like history taking, and is also has access to your medical records with your permission. It then uses those medical records and its known learned skills to basically conduct a portion of the visit on its own, and then to invite a doctor into that same chat conversation when you choose. When the doctor joins the conversation, we have built what we call a clinician cockpit. Think of it like Claude for doctors, where our doctors in the back end, rather than keystroke by keystroke typing responses, have the advantage of an AI that's doing the entire record parsing and review, that is surfacing, hey, this paper just came out 2 months ago that actually may have a guideline on how we should treat this patient. And to your question, part of what the clinician cockpit's doing is it's also surfacing prior conversations. So, hey, Michael is coming to us with back pain. He told us 4 years ago he had back pain after running a half marathon. I suggest we ask him whether he's been on any runs recently. And so that's the kind of thing that, as a PCP on my own, my ability to remember that the same type of back pain syndrome happened 4 years ago after a marathon, even if it's in the medical record, nearly impossible. Well, we can do that type of inference, in milliseconds, in real time, conversation by conversation, and that becomes the real magic of sort of the AI augmentation.
There are a lot of AI assistance tools that are designed to operate in the in the place where patient care is being delivered. One of the things that I in my research was different or unique about Counsel is that you do employ a team of physicians. Maybe talk about how that's unique versus the voice badge approach or various other approaches that might seem like alternatives to Counsel.
Yeah. So from an early kind of perspective on Counsel, we wanted to be the clinical service itself. So although we build frontier AI applications, at the end of the day, we're in the business of taking care of people when they have medical issues. And the way we do that is by hiring and operating our own medical group. So we hire physicians, we employ physicians, and those physicians deliver care to patients. Now, we've constructed an entire care model around how to do that best takes advantage of AI. So our care model is entirely messaging based, because in messaging, we can have an AI every turn, every response on the conversation weigh in a way that a video visit or an in-person visit, it's really hard to have an AI sort of intercept the conversation with guidance or suggestions as it's going on. But yes, ultimately, we're a medical practice, and we deliver care virtually and via messaging, and we use AI as a form of augmentation of that care. Now, along the way, we've had to basically invent new care models. Right? We've sort of made popular this idea of messaging-based clinical interactions. We've designed a clinician cockpit. We've built evaluation frameworks, but ultimately, we see ourselves as a provider group. Now, the other part of your question, so part of the reason we did that is because we want to actually deliver care to patients, and the best way to do that is to have your own physicians. The other reason to do that is that we can construct really effective feedback loops from our doctors back to our AI. And so think of our AI as sort of being in medical school, learning from our doctors in every single conversation. So while the AI is helping the doctors are also sort of feedbacking and training the AI, and they're sort of learning passively in that way. And when we think about getting to a world of fully autonomous care, we think it's so important to have these feedback loops implemented in real time and at high volume. And so part of this is is a way to accelerate the path towards fully autonomous care as well.
If I can grossly oversimplify the history of healthcare, and I'm not a doctor, I'm just speaking from the perspective of a patient and want to get your feedback on this. If maybe kind of 1.0 was, like you alluded to, kind of community-based care, and maybe 2.0 was physician-based, maybe in a clinic, and maybe 3.0 is what we're entering now, kind of AI first, physician-assisted. Is there a 4.0 where it's AI based and potentially, the physician is an escalation point only after the robot, the robot has been inserted to do the procedure, et cetera. And the humans are really a last resort because a combination of AI and AI driven robotics are doing a lot of what is required for a medical facility today.
I think that progression, as you've laid it out, is very reasonable. And, just like you said, one way to think about it is that the first 25,000 years of human history, care was fully human. So one end of the spectrum, everything from healers and caregivers to doctors who came to your home to doctors in the clinic. But we lived in this fully human world. We're now in the semi-autonomous world and have been there for some years. I would even classify, someone Googling their symptoms as semi-autonomous. It's their form of sort of getting software-based advice and then deciding whether to go to urgent care or not. It's still semi-autonomous, and Counsel is bringing semi-autonomous much more into focus with much less friction. Rather than going to Google and then going to urgent care, you can essentially talk to your AI and then talk to a doctor all within a couple minutes in the same interface. And to your point, it's not hard to imagine that there is some future state where you are getting all of the care from an AI, even if it requires in-person, vaccines or lab tests or procedures, that can be done with a robotics effector arm. And it's hard to opine on how far away that may be, but at least the software component of that, the fully autonomous cognitive piece, it feels like we're not too far away, a matter of years, not decades. And then on the robotics side, we'll see. But I think that is seemingly where we're headed. And I think there's reason to be excited about that because I live in Boston. There are 5 level 1 trauma centers here and some of the best doctors and hospitals, but not everyone lives in Boston. And so the idea that you can democratize the best versions of medical care, both cognitive and procedural, to everyone in the world at dramatically lower cost is something I think humans have been sort of needing to happen forever. And the idea that your zip code or your bank account should not dictate the quality of care you receive, I think is sort of a universally agreed upon good in the world. So I think that's the future we're excited about.
I love that you went there. I've heard you previously make a comment. Don't believe that you hit a triple because you started on third base. And that resonated with me. And specifically, I think, for everyone listening who says the idea of, robotic healthcare, is distasteful or, how could that possibly be better? Well, I think it's worth considering, what an upgrade that would be for, I don't know the numbers, but high 90%, right? I mean, the vast majority of the world doesn't have the luxury of having a clinic, like you in Boston or me in Silicon Valley. And I think we need to think about, all the amazing possibilities of improving lifespans and health spans, I should say, with robotics. And I think it's not too big of a leap of faith to say most clinics today are essentially, computers that are augmented by humans, but so much of the diagnostics, the procedures, the assessments are today being done by computers, right?
Yeah, there's a lot of treatment planning and even the aspects of the procedures themselves that may be computer assisted. I mentioned polyp detection in colonoscopy is now quite a bit more popular. That you would use image detection to help you not miss a polyp during an endoscopy. Radiologists are using this to not miss nodules and other findings on chest X-rays. So this is starting to become more mainstream and the first iteration of Counsel, we used to often say we're productizing what it's like to have a doctor in the family. This idea that some folks are lucky enough to have a doctor in the family, and my dad's a physician, and I remember growing up, we would we sort of had every subspecialist on speed dial from one of my dad's, medical school friends or colleagues, and it was this amazing privilege. And we sort of have the same with my colleagues in medicine, but not everyone has that. We sort of asked the question: what if we could productize that? What if everyone could feel that way? And I think that is extremely exciting, and hopefully will be a reality not too far from now.
I mentioned the fun fact about kind of the ethics behind how and when it's okay to use data, other people's data, make decisions with AI. Would love to know from your perspective, both as a physician and as a CEO, where do you feel like is the line that you wouldn't cross in terms of when it's inappropriate to use even technologies like Counsel to deliver patient care?
So I think there's a few things that we care a lot about here. One is we care about really rigid, even federally regulated standards around AI safety and security. There have been incidents, even in the clinical AI realm, of platforms that have had prompt injections, prompt attacks that have been able to convince the AI to say something that it wasn't trained to say, or to manipulate the conversation. And it does feel like there needs to be really strong industry standard safeguards, benchmarks to make sure that doesn't happen. So I think we're really quite particular on that. The second thing, and we and others have written about this, is something called values in the model. But the models are pre-trained by the frontier labs on a lot of data. And implicit in that data is a certain sort of value orchestration. And so in healthcare, a very simplistic example is that the pre-training could push models to be in favor of a fee-for-service environment where they're pushing patients to get more tests, more procedures, more visits, because that's what the underlying data implicitly wants. Or it could be the opposite of like the avoidance of care to save money for an insurer or a payer. So like pushing people away from care. And it's not clear often what the implicit value system of a model is. And so one thing we're really interested on the research side is what are the evaluation benchmarks and tests to extract what the value framework is for a particular model? And how can we make that really transparent? So if there's a particular AI system for prescribing heart failure medications, how does the whole world know what is the implicit value framework behind this model, so that we all know what it's kind of likely to want to do? So that's another area that we're really interested in. Now, on the data side, we generally believe that patients are the owners of their medical data and should have full responsibility and ability to dictate how that data is used. And so we will obviously always ask users for permission to even use their data to help in decision making. We don't use their data to train models or to tune models, and a lot of that is sort of industry standard, but I think it's very important to maintain.
Yeah, it's a complicated topic because I think everyone who's steeped in AI knows there's inherent bias in the training data, goes into building these models from the foundation labs. Probably more affluent data, or data from more affluent populations are represented, probably that represent certain parts of the world, even certain colors of skin, even certain genders, certain lifestyles. And so that can seem problematic, knowing that so much of the world is now relying on this data that is biased. The flip side of this conversation, which you alluded to earlier, is that patients should also consider that when they're interacting with one physician in one session, the physician's perspective on the world is also biased. So I think we all have, everyone, global society, we have to make a decision about which bias we're more comfortable with. And, I think it's early stages, but we'd love to get your perspective on how we trade off the two sets of biased data.
Yeah, no, I think it's a really salient point. I think a lot of people have been making it appropriately, which is that there's a real, double standard being applied between AI and humans. And a lot of these same things that we can point out as flaws in AI are actually more pronounced in humans. So the values question, you interact with a physician who works at a fully capitated, at-risk care delivery system versus a physician who's operating a local private practice fee for service, they're going to have very different recommendations on what to do next when you come to them. Where one person is going to try to maybe do conservative management, and the other one's going to maybe recommend tests and procedures. And it could be implicit, it could be subconscious, but everyone's sort of operating under their own set of values and biases. And I think it's more pronounced in humans. I think it's harder to elucidate what the values are in humans. There's more, it's almost easier to cover it up, and there's more fragmentation. I think that the exciting thing about AI is that we can actually get to the ground truth of a lot of this in a lot more objective manner. Like, we can run these evaluation suites by an AI to elicit its values. We can benchmark it every day. Like, humans, as a doctor, I take my boards every 10 years, and we could have an AI do it every night, and it's not going to complain. And all of that to say, I'm actually in favor of a higher standard for AI than humans, partially because I think an AI has the ability to live up to it. And so we should hold it to a higher standard simply because it can actually perform accordingly. Like, with human doctors, I cannot set the board pass rate at 98% because we would have 10 doctors in the world. But with AI, we can. And so why shouldn't we hold it to a higher standard that's able to pass? The second reason that I think an AI should have a higher bar than humans is because the best AI systems are going to be providing care at 1,000x the volume, 1,000,000x the volume than a single doctor, right? And so the failure mode becomes easily exploitable, so to speak. And so a 1% error rate of an AI that's doing 1,000,000 visits a day is actually really problematic. A 5% error rate of a human that's only doing 10 visits a day is from a total net bad perspective, it's less. And so I think all of that to say, there's some interesting discussions as a society to be had on the double standard and whether it should exist, and if it does exist, how deviated should those two be.
So you, the physician, and you as previous roles in venture-backed companies, kind of have this vision for Counsel. You talk to a lot of entrepreneurs, maybe first-time entrepreneurs. Talk us through your journey and going from kind of founding vision to getting the company funded and starting to build, a category-defining company. How's that been for you?
It's it is an incredibly challenging and rewarding journey, I think, on every dimension, in terms of what it teaches you about self-confidence and self-awareness, and the trade-off between sort of having enough confidence to go for something that maybe the rest of the world does not yet have conviction in, but having enough humility and self-awareness to make micro pivots depending on what the industry is teaching you. Your relationship to other people. I feel like I am extremely accountable and responsible for every one of our customers, every one of our patients, every one of our employees, every one of our investors. Any of those people can call me any time of the day, and I would feel excited and obligated to pick up the phone. So there's a mentality there. I think you realize I've realized the importance of two things that I think I always knew were important, but believe are even more important. One is the quality and the principles of the team you recruit, and how important it is that every person in every role, especially early on, becomes sort of the DNA of the company that gets multiplied. And how there is, this is often said, but it cannot be overstated, how important it is to get the people right, and the principles of those people matter greatly in terms of the decision making of the company. The company will take on a ethos and a set of values that are embodied by those people. The second thing is the compounding value of reputation. Everyone at Counsel will interface, like all of our people will interface with the outside world, maybe a handful of times per day. But the people we interface with will interface with the world many more times, and that compounds. And I think one of the things that we've really seen the value of is, if we carry ourselves the right way, if we operate with integrity, if we have the right principles, and we build a good reputation, the compounding value of that across the industry, across patients, across investors, and all of that is so valuable. And it's far beyond our ability to impact it on a day-to-day basis.
Yeah, well said. We're about out of time, but you're not getting off the hot seat without answering one last important question for me. And I watched clips from you gave the commencement address when you graduated from Stanford Medical School, and would love to know, if you were to roll back the clock, how would you change that commencement address if you had to give it today?
So first of all, thank you for I guess going back into the archives and doing all the homework. It does mean a lot, and I appreciate it. That's a really good question. I think the main thing I would maybe change or update is that um, medical school was 4 years of training based on the history of medicine that had preceded us. But it was probably not sufficient training for adapting to the many ways that medicine would change in the future ahead of us. And probably just a message around um, appreciating and honoring everything that we've been taught, but also recognizing that we don't really ever leave medical school. Like the rest of our careers will be an exercise of learning, adapting, testing ourselves, convincing ourselves we still are up for the job, and treating medical school maybe like the rest of our careers as opposed to a moment in time.
Well, maybe if the dean of Stanford Medical School is listening, you'll get invited back to do an encore performance. That would be a good talk.
I would not say no to that. So thank you for planting the seed.
Excellent. Well, where can the audience learn more about you and the great work that Counsel's doing?
We are hoping and intending to be increasingly transparent with our views on the world. As we're sort of building at the frontier of the space, we view it as our responsibility to share the good and the bad of what we're seeing, of how we're thinking and tackling these difficult problems. We'll put a lot of that writing on our own website, which is counselhealth.com. We are really proud of the product we've built, which is accessible on our website as well. And we'll also look to share more in the peer-reviewed and academic literature. That's always, for doctors at least, that has been the verifiable source and way of pushing the field forward. And we look forward to contributing our findings, again, both good and bad, into that ecosystem of knowledge, so that everyone can learn and advance because of it. So I would say our website, our personal LinkedIn's where we post, but then also hopefully the peer-reviewed literature in the months to come.
This has been fascinating. I appreciate you making time. Thanks for hanging out, and we are all rooting for you and the team. Best of luck.
Yeah. Well, thank you so much, Dan. This was a lot of fun. I appreciate you having me on.
You bet. Well, that is all the time we have for this week on AI and the Future of Work. As always, I'm your host, Dan Turchin from People Rain. And of course, we're back next week with another fascinating guest.
Yo, it's the end of the show, time to power it down. AI's the sis, but humans wear the crown. Team Human in the house, got the vibe so clever. Dan Turchin from People Rain, making us better. We learned about AI for humans. We're ready to conquer the future, that's all for now. See you next time.